Okay, now we will be moving on to the first talk of the day, the first recording, Dr. Hoang. I would like to briefly introduce the CV of Dr. Hoang. So to give you a little bit of context, he has been the director of the ART Center of Tam Anh General Hospital since 2017. And he is also the vice president of Hanoi ART Association. He's the honorary member of the French College of OBGYN, the CNGOF, and a member of the Executive Committee of Vietnam Association of Obstetricians and Gynecologists. Finally, he's the secretary of Vietnam Society for Reproductive Medicine and also the member of the American Society of Reproductive Medicine. And we'll be playing his recording for you right now.
Good afternoon, everybody. First of all, I would like to thank Igenomix for inviting me to talk about ERA EMA are listed on RIF patients in our center. As we know, RIF recurrent replantation failure is one of the most difficult things in IVF. The etiology of IF is not clear. There is no accepted formal definition for IF after 3 failed in vitro fertilization embryo transfer. After 3 unsuccessful cycles of IVF, especially with 2 embryos of high quality. IF as failure of clinical pregnancy after 4 good quality embryo transfer with at least 3 fresh or frozen IVF cycle and in women under the age of 40. Copeland suggests a more complete working definition taking into account maternal age, number of embryo transfer, and number of cycles completed. It was mentioned about the embryo and the endometrium can both play an active role in recurrent implantation failure. How about the incidence? The incidence of IF in the world in 2006 is about 10% of cycle, depending on the definition. IF can impact to the couple, make the patient distressed, to the doctor. It makes an increase on the cost of IVF, impact on management, and IF still major challenge to the clinician and embryologists. Last year, 2021, in Israel, post-PGT has a retrospective cohort study on more than 4,000 patients with normal uterus with 3 consecutive aploid frozen transfer. He found that the rate of RIF is about less than 5%, not too much. There are many risk factors for RIF. First of all is the age of the patient. With advanced maternal age can affect to embryo quality and endometrium receptivity. The second is the sperm DNA fragmentation. The stress of the patient also affect on the result of IVF. The infection. There is a lot of articles talk about infection, especially in chronic endometritis. And other risk factor is immunology and endocrinology, etc. How about the intervention for RIF in the world? There are a lot of methods for treatment as lifestyle modification, treatment uterine disease, antibiotic for infection, embryo factor, antithrombotic agent, the immunotherapy pre-implantation genetic screening, endometrial biopsy, and progesterone support. In our center, IVF Tam Anh Hà Nội, Việt Nam, there are about 3,000 to 4,000 IVF cycles a year. Our definition of RIF is after 3 failed in vitro fertilization, embryo transfer. The rate of RIF in our center about 7%, a little higher than other center in Vietnam, because we have to receive the severe patient from the other center. There are many methods for treatment RIF patient in our center. First of all, we do office hysteroscopy. We always ask patient to do office hysteroscopy if they have RIF. We always do at the day 2 to day 3 after stop bleeding. By hysteroscopy, we can verify the uterine cavity is normal or not. Here is some picture of RIF patient in our center. Here's adhesion, here's polyps and adhesion, and endometritis. For this patient, small polyps and small adhesion, we remove polyps and cut the adhesion by hysteroscopy. And for the endometritis, we can biopsy the endometrium for testing. The second is transfer blastocyst embryos. We know clearly about the quality of blastocyst embryo. We try to transfer blastocyst embryo for the patient with RIF. We prefer use a frozen embryo transfer. With blastocyst embryo transfer, we have the rate successful in RIF is about 40%. And the next is a pre-implantation genetic testing. We do all these things: PGT-A, PGT-M, PGT-SR. By PGT, we can choose high quality embryos without abnormal chromosome, so that the successful rate is higher. Endometrial scratching. There is controversy about endometrial scratching, but we also use endometrial scratching for RIF patient. We only do the scratching for RIF patient on the day 21 of previous cycle. It works for some patient because it's not expensive, and it works. The next is a platelet-rich plasma autologous. We use PRP for the patient with RIF. We use PRP during the endometrial preparation. The success rate in RIF of PRP autologous in our center is about 56%. And the last, I want to talk about ERA, EMA, and ALICE test. With EMA, ERA, ALICE test, we can know the exact day of implantation window and analyze the endometrial microbiome and diagnose chronic endometritis. Now let me talk about ERA, EMA, ALICE test in our center. All of the patients in our center do EMA, ERA, ALICE test. First of all, we have to eliminate all the abnormal uterine cavity of this patient. There are 20 patients in our center doing ERA EMA ALICE test. 16 of them has a frozen embryo transfer. And I will talk about this patient. The mean age is 35 years old. 7 of them is primary infertility. The mean cycle of filler implantation is about more than 4 times. About ERA, we divide the ERA the result in 3 groups. Group 1 is about 118 hours to 122 hours. As a protocol we use for the own patient with frozen embryo transfer. There are 16 cases in this group. 12 has a frozen embryo transfer. 6 has pregnancy. Live birth 3, ongoing pregnancy 2, and 1 semicolon pregnancy. And the group 2 is long, 146 to 148 hours. We have 3 cases. All the cases have recommended to redo the biopsy, but the patient doesn't want to do. We do the frozen embryo transfer for them, 2 ongoing pregnancy and 1 filler. The last group is a short time, 110 hours. There is only 1 patient. Luckily, she has the baby now. EMA result. Normal result of EMA, there are 7 cases. 5 has been frozen embryo transferred, 2 live birth, 1 ongoing pregnancy, and 1 chemical pregnancy, 1 filler. This filler case is she has ERA test in long group 146 hours. The second group is microbiome with ultra-low biomass and my dysbiopsy profile. There are 9 patients. They were prescribed vaginal probiotic contain lactobacillus treated. 9 of them has frozen embryo transfer, 2 live birth, 3 ongoing pregnancy, 4 filler. The endometrial microbiome, there are 4 patients. They was given metronidazole 500 milligram for every 12 hours for 7 days. 2 has frozen embryo transfer filler, and 2 last not has the frozen embryo transfer yet. And about ALICE result. The 19 cases have the normal result. Only 1 patient has endometritis. She was given treatment by amoxicillin for 7 days. Overall, in the successful group, we have 9 patients with pregnancy. 5 patients have abnormal result of EMA test. There are 8 patients was transferred with blastocyst embryos. In the group unsuccessful, there are 7 patients. 2 of them was transferred with cleavage state embryo, and 5 with blastocyst transfer. 6 of 7 patients in the group normal 118 to 122 hours post-gestation, but all of them with abnormality in EMA test, they has treated, but they don't want to retest after treatment. The last the patient of this group is a woman 47 years old. In the group long of ERA 146 to 148 hours. She has only cleavage state embryo transfer. With EMA abnormality, she had treated, but she doesn't want to retest after treatment. The conclusion: recurrent implantation failure is a complex problem with wide variety of etiology. The recommendation for women with IIF vary depending on source of the problem. Personalized treatment is needed. Consider oblatosis embryo transfer if possible. The test should be repeated in case of doubt or after treatment. Thank you for your attention.
Thank you, Dr. Juan, for this nice presentation you put up, especially for this event. We really appreciate you agreeing to be here for the Q&A session, even though you have a COVID condition. So we really appreciate you being here. We already have a few questions here in the screen. So I would like to start with what we have right now, Doctor, if that's okay.
Yeah.
So first of all, the first question that we received is, do you recommend ERA for patients who have failed embryo transfers only 2 times? And if so, can you give us some specific examples?
Yes, as we know, ERA test is very useful for treatment, but is in my opinion, is we cannot use for everybody, every patient systematically because it's expensive. We in our center we will suggest patient use a ERA test when she has a RIF. If the patient want to do, yes, of course she can. But we don't ask every patient to do ERA test for everybody. Yeah.
Okay, understood. Thank you so much.
Normally we have 2 cases as for ERA test, but I don't list it in here. I don't want to put it in this presentation because she's not IIF patient. But the result is normal. In the normal group, that the progesterone exposure time is about 4 day, 4.5 days and to 5 days as a protocol we as used for everybody, every patient. So, for my opinion, I don't suggest use an ERA test for every patient.
Understood. Not for all of your patients then, the recommendation. I will ask another question that arrived in the chat for us. So do you mostly use programmed or natural transfer cycles?
Yes, natural cycle is very good now. If the patient have a regular cycle, we use a natural cycle, but it's we don't use a really natural cycle. We use a modified natural cycle.
So most of your cases are modified.
Yes, if she has a regular cycle.
Understood. Thank you, doctor. We'll move on to the third question that arrived for us. Someone else asked, when do doctors need to repeat an EMA test? What is the rate of patients who need to repeat this test at your center?
Yes, it's a very good question. Yeah, I think if the patient has the abnormal EMA and ALICE test, after treatment, she should do a retest again. Because we want to check is normal or not after treatment. The problem is expensive. almost patients in our center, they are IF, so she had to pay a lot of money for the cycle before. So almost of them doesn't want to do it again. But I think in my presentation, I told about of EMA test, we have about 20% patient with abnormal endometrial microbiome. This person, for me, she should do again the EMA test after treatment. And if at least we have only one patient, it means that's about 5% if endometritis. Normally, after treatment, she should do the test again, but all of them they doesn't want to do again. Sorry.
Yeah, after all, is another biopsy that the patient has to
Yeah.
undergo. But anyhow, you do recommend that the patient confirms that the treatment has worked before going on with the transfer.
Yes, we after treatment, you will ask patient to redo again for make sure that it's normal or not. But because we don't have the evidence about the endometrium is normal or not, but the patient said, oh, it's okay, I'm feeling good now, no discharge, no abdominal pain, etc. So please transfer for me. So she said to me that, so you cannot do another way.
Okay. We have our last one now. For the doctor, will you do endometrial scratching along with the URA test? Do you do that procedure as well?
Yeah, we do endometrial scratching, but not too much. But we use it for patient. We don't have we don't found any trouble, any abnormal in uterine cavity, in immunology, in anatomy, etc. So she cannot afford the ERA. First of all, I always ask patient to do ERA, EMA, and Alistec for the patient, but she doesn't want to do it. So no way. I do the stretching for IF patient. I want to say that for IF patient only, but not for every patient.
Okay. Thank you very much, Dr. Hoang, for answering your questions. So this is how Dr. Huang's perspective at his IVF center in Hanoi, Vietnam. Thank you very much
Yeah.
for joining us today.
Thank you.